or 2 minutes. Yes, sir. We'll be waiting another 1 or 2 minutes, sir. To Dr. KP Shamsuddin sir about to join, sir. Welcome, Dr. KP Shamsuddin sir.
Yeah. Thank you.
Thank you. So your audio and video is very good, no, sir?
Yeah.
Sir, good evening. My name is Omkar. I am from Mumbai, HO. Welcome. How are you, sir?
Yeah, fine.
Just to brief you today evening, sir, a flow of events, sir.
Yeah.
So today basically it's a debate discussion on the 2 case studies. I hope you are aware about it, sir.
Yeah.
So after Ganeshan opens the debate, he will introduce you as well as all the panelists, and then he will hand over session to you so you can present the cases. Is it fine, sir? Or
yeah, I'll just present the cases and then I'll leave it to the panelists to discuss.
Yeah, exactly.
Okay. So the slides you will share, or
I'll share from backend from here, sir.
Fine.
So this will be the slide, sir. So we will be going on first ACS, then AF will be doing on the case study.
Okay, fine. Yeah.
So in a couple of minutes we'll be starting, sir. We are waiting for one more doctor to join.
Okay.
Right, Ganeshan?
Yes, sir.
Yeah.
Sir, Dr. Muthia sir about to join, sir. He will take another 5 minutes, sir, because he's there in ICU, like that, he said, sir.
Okay. Fine, Ganeshan.
So we will wait another 2 minutes, sir. Then we will start our proceedings, sir.
Great, definitely.
Right. Sir, now it is 4:02, sir. So shall we start the session now? By the time he will join, sir, another 5 minutes, sir. So is it okay now, sir?
Yeah, I think we can start. So I think Muthu
Yes,
sir
sir.
will join in meanwhile. Na?
Yes, sir.
Yeah, Amrish ji, please go live.
Yeah. Give me just 1 minute. Let me just do it live for audience.
Yeah, just a moment, Ganeshan.
Yes, sir. Sure.
Yeah, now we are live. You can start.
Yeah, Ganeshan, please
Yes,
start.
yes, sir. So good evening, one and all. On behalf of Alchem Laboratories, India's 5th largest pharmaceutical company, I welcome our eminent moderator, panelists, and all doctors who have joined us for today's antithrombotic debate. At Alchem, it has always been our endeavor to partner with healthcare professionals, and we continue to do so. Sir, with this opportunity, I'm introducing Dr. KP Shamsuddin, sir. To help us navigate through the meeting, we have with us our renowned cardiologist, Dr. KP Shamsuddin, sir, who will be moderating today's debate. Welcome, Dr. KP Shamsuddin, sir. And Dr. KP Shamsuddin, sir, he is practiced in Isabel Hospital, Chennai. He is a consultant interventional cardiologist, Bilrath Hospital, Saryapuram, Chennai. And he is practicing from 2012 to till now, visiting consultant interventional cardiologist in Kaveri Hospital, Chennai. He is a visiting consultant interventional cardiologist, Venkateswara Hospital in Chennai. And he started from 2016 to till date, he is a consultant cardiologist at Olive Heart Clinic, Alvarpet, Chennai. He did his MBBS in 1993 Rajas Muthiah Medical College, Annamalai University, and he did in MD Medicine in Madras Medical College, and he has done DNB Cardiology in Vijaya Heart Foundation, Chennai, National Board of Examination, New Delhi. He did fellowship in cardiology in Vijaya Hospital, Chennai. And let me introduce Dr. Ramanathan Ramkumar sir. He did MBBS in 2000 RMMCH Annamalai University, and he has done MD Medicine at 2008 RMMCH Annamalai University, and he did IDCCM Critical Care in Sundaram Medical Foundation, and he did DNB Cardiology at 2008 Railway Hospital, Perambur. With that, let me introduce Dr. G.D. Surendran sir. Dr. G.D. Surendran sir, he did UG from Stanley Medical College, and he did MD and DM from MMC Chennai. So with that, let me hand over the session to Dr. K.P. Shamsuddin sir. Please take over the session, sir. Thank you so much.
Thank you. First of all, I thank Alcom for calling me to moderate this session, which is very important in our day-to-day practice. And I also welcome Dr. Ramanathan Ramkumar and Surendran for this. And also I think Dr. Muthiah will be joining. Now, see, we all treat a lot of patients with ischemic heart disease and valvular heart disease in our day-to-day practice. But then see, this thrombosis and thromboembolism is one of the major cause of deaths in various forms like acute coronary syndrome, maybe acute CVA, pulmonary embolism, DVT, cardioembolic stroke due to atrial fibrillation, etc. And if you see, there are two classes of antithrombotic drugs. One is an antiplatelet drugs like aspirin, Clopidogrel, ticagrelor, prasugrel. And the other one is called as an anticoagulant. Actually, combining both will have a better effect, but at the risk of slightly increased bleed. And since 1916, first when the heparin has been introduced as an antithrombotic, almost for a century, we have been using the same molecule. And apart from that, there are a lot of newer molecules which is added to the into the pharmacology for our use in our patients. So a lot of situations, mostly we use only antiplatelets in coronary artery disease, but of late there are a lot of indications for antithrombotics, anticoagulants to be used in acute coronary syndrome. Mostly when the patient with CAD has an atrial fibrillation or a pulmonary embolism or DVT, or of late in COVID patients, we are forced to use anticoagulants. So I think in here we'll be discussing about combination of antiplatelets with anticoagulant, and there are two different combinations which are approved, like either dabigatran along with ticagrelor or rivaroxaban along with either prasugrel or clopidogrel. Now we'll start the meeting with I'll just present real world cases, like two example cases. So case one is a 72 years old male who comes to the emergency department complaining of sudden onset chest pain since 1 hour, and pain was typical of cardiac origin, and he's a smoker, non-diabetic with history of hypertension, and ECG shows typical extensive inferior wall MI, cardio biomarkers were positive, blood pressure of 130/70, and pulse of 70 millimeters mercury, and ECG shows a typical acute inferior wall MI, and he is willing for intervention. So which drug, which antiplatelet to be used in this patient? Of course, there are differences of opinion. So we will see what our panelists want, which antiplatelet they prefer and why, and what is the reason behind this. So this patient is specifically an inferior wall MI who is willing for intervention. So when the patient is willing for intervention, the antiplatelet regimen is different. And if they are not willing for intervention, it is different. So we'll look into it. And the other case is, next slide.
Sir, Dr. Muthaiya sir has joined, sir.
Okay, very good.
Welcome, Dr. Muthaiya sir, to this
Yeah.
forum.
You can go to the next slide. So this slide is typically of an ACS inferior volume and willing for acute intervention. So we'll see what panelists want, which antiplatelet they prefer. And other case, you can just move to the next slide. Okay, I think this patient will go in for a PCI, and definitely they will have proximal RCA lesion and probably a stent to the circumflex also. It needs two drug-eluting stents. Next slide. So in this patient, which antiplatelet use and the dosage as well as the duration. So the aspirin loading dose with aspirin along with a clopidogrel of 300 mg, or aspirin loading dose with a clopidogrel of 600 mg, or aspirin along with prasugrel 60 mg, or aspirin along with ticagrelor 180 mg, which is the best antiplatelet in this patient. Next slide. So the treatment of acute coronary syndrome, the initial treatment of ACS, if it is ST elevation MI, we allow to load the patient with antiplatelet, give anti-ischemic drugs like nitrates, and going for an anticoagulant therapy. Either you can go in for a thrombolytics, or if the patient is willing for a primary PCA, you can take them for angio followed by PCA or a CABG. If it is unstable angina or NST elevation MI, same, we'll have to give antiplatelets, anti-ischemic drugs, and anticoagulant therapy. And then later on, probably you can take them for a PCI or a CABG and followed with a long-term medical management. So here the antiplatelets varies from ST elevation MI and NST elevation MI. And if the patient is willing for intervention, the antiplatelets also varies. And if the patient is not willing for intervention, probably we'll have to give a different antiplatelets. Next. See, these are the various targets for platelet inhibition. So we all know about the ticlopidine and clopidogrel and prasugrel, which acts at the ADP level, and the ticagrelor, the newer antiplatelet, the ticagrelor, cangrelor, and erinogrel, which is a P2Y2 inhibitor, and thereby it inhibits the platelet activation. And on the other side, we have heparin, fondaparinux, bivalirudin, rivaroxaban, apixaban, and dabigatran, which directly inhibits the factor 10A, and thus combining antiplatelets along with an antithrombotic, we get a complete inhibition of platelets, and thus we can prevent the further formation of the thrombus in a patient with acute coronary syndrome. And of course, during intervention, we use GP2B3 agonist, where it acts at a different level, at direct fibrinogen level receptors. So these are used only when we do an intervention. Next slide. Of course, P2Y2 receptor biology and existing antagonists like first generation was ticlopidine. Now it is no more used. It was replaced with clopidogrel, which is the second generation. It is widely used. And the third generation of same molecule was prasugrel. Then came in a different molecule, that is cyclopentyl triazolopyrimidine molecule, CPTP molecule called as ticagrelor, which is more, more effective and powerful than clopidogrel, with slightly increased bleeding risk. But of course, any patient whom we are planning for a primary intervention, then I think we always prefer ticagrelor over clopidogrel or prasugrel. Of course, some people still use prasugrel depending on their individual choice. Next slide. Now, there are a lot of potential limitations of clopidogrel, like requirement of metabolic activation, because clopidogrel is a prodrug, so it has to be activated when it passes through the liver, and there is a moderate overall levels of platelet inhibition is around 55%, and there's a high variability response within a population around 25 to 30% with very low levels of platelet inhibition. So all patients who are given clopidogrel doesn't have a complete inhibition of platelets. And it is a slow onset of antiplatelet effect requiring almost 300 to 600 milligram loading dose in acute phase, and it takes a little time for its action. And irreversible P2Y2 receptor binding is requiring platelet replacement for return of activity. This is it's an irreversible receptor binding. And sometimes if the patient has a bleed, then we may have to give a platelet replacement if the patient is on Clopidogrel. So whereas if you see the newer molecule as ticagrelor, it causes only a reversible receptor binding. But next slide. Yeah. So this slide shows the clinical outcome of clopidogrel resistance. There are some patients who are resistant to clopidogrels and also aspirin. So various studies shows that there was a slightly increased major adverse cardiac events in patients with clopidogrel non-responders, or we call it as a clopidogrel resistance due to various genetic predisposition or some lack of some enzymes. They have seen that some patients don't respond to clopidogrel, and there is a definitely increased MACE with such non-responders. Next slide. Some patients even post PTCA, we have seen stent thrombosis even after giving double the dose of clopidogrel. So such probably they are non-responders to clopidogrel, and we'll end up with such issues. So can more be done with P2Y2 antagonisms? So increase in levels of IPA, probably yes, reduced variability, and increase the speed of onset of action. That is clopidogrel, the maximum Tmax is around 4 to 6 hours. So inhibition of better inhibition of platelet aggregation and reduced variability and increase the speed of onset. Definitely all of them will prefer all these three, especially when a patient whom we are planning for an intervention, because we get a better antiplatelet effect even before we start the intervention. So these are all the, negative points of clopidogrel, which when these are corrected, next slide, definitely we get a better molecule. That is called ticagrelor, which is an oral antiplatelet treatment for ACS. And it's a directly acting P2Y2 receptor antagonist. And it doesn't require a metabolic activation, unlike clopidogrel, which is directly acting. And it has got a faster onset of inhibitory effects on P2Y2 receptor than the clopidogrel. And first, reversibly binding oral ADP receptor antagonist. Note the point, it is reversibly binding and active in systemic circulation throughout the dosing interval. And it has got higher and more consistent platelet inhibition when compared to clopidogrel, which is proven in vivo as well as in vitro. Next slide. So when compared to clopidogrel, ticagrelor can do more with P2Y2 antagonisms. It definitely increases the level of inhibition of platelet aggregation. It is proved by various trials, and reduced variability and increase the speed of onset of action of antiplatelet. So when compared to clopidogrel, which has a Tmax is around 4 to 6 hours, whereas if you give ticagrelor, you can have an early onset of antiplatelet action and the peak reached by around 1 to 2 hours. So definitely ticagrelor is superior to clopidogrel in the early onset of action, better efficacy, and relatively good safety too. Next slide. So here they compare all three major antiplatelet like ticagrelor, clopidogrel, and prasugrel. The chemical class ticagrelor is different from other two, and ticagrelor causes reverse inhibition of P2Y2 receptors, whereas prasugrel and clopidogrel causes irreversible inhibition. And genotype variation is not seen much with ticagrelor when compared with clopidogrel. And dosing ticagrelor is twice daily, whereas clopidogrel and prasugrel is once daily. And the mean inhibition of platelet aggregation at 30 minutes around 41% with ticagrelor, whereas it is only 8% with clopidogrel and 31% with prasugrel. So that is the reason why prasugrel and ticagrelor is preferred when a patient is planned for a primary PCI or an intervention. And mean inhibition of platelet aggregation at 2 hours around 89% with ticagrelor, and it's only 38% in clopidogrel and the procedural is around 80%. So overall, when you compare these three, definitely ticagrelor is stand at the top when compared when these main factors like platelet inhibition is taken into consideration. Next slide. Of course, we all know about this plateau trial. Ticagrelor compared with clopidogrel in patients with acute coronary syndrome, and ticagrelor was loaded in patients with acute coronary syndrome in this trial. Next slide. So when the patient comes with ACS to the emergency room, the initial ECG was taken. 40% of the patient were ST elevation MI, and 40% was NST elevation MI, and 20% unstable angina. They were started on antiplatelet therapy with plateau randomization and invasive or catheterization laboratory, and they have taken for an angiogram and determine the anatomy, and then decide whether they go in for a medical management, PCA or STABG. And accordingly, if they are going for CABG, you'll have to stop the antiplatelet therapy. And for PCI and medically managed patients, they continued with antiplatelet therapy. Patients were loaded with 325 milligram of aspirin, and if tolerated, all patients received aspirin 75 to 100 milligram daily if no stent was placed, and 325 milligram daily once for 6 months if the stent was placed, along with ticagrelor. So when medically appropriate, of course, antiplatelets are stopped if they have any bleeding and other complications, or if they are going in for CABG, they have stopped the antiplatelet for a short time. Next slide. So the primary efficacy point was endpoint was a composite of cardiovascular deaths, MI or stroke, and 12 months follow-up was done. So when they compared, after the initial randomization, patients who were received ticagrelor had a 9.8 cumulative incidence of these three major endpoints, whereas it was 11.7 in clopidogrel. There is a cumulative incidence of severe death, MI or stroke, the significant reduction in all these events in patients who are on ticagrelor. Next slide. So if they see the plateau invasive selective patient stent thrombosis, there was a definite stent thrombosis in around 2% of the patients who were on clopidogrel, and only 1.3% of patients with ticagrelor. And if you see probable or definite thrombosis was 2.2 and 3 in clopidogrel, and possible, probable or definite thrombosis, it was 2.8 in ticagrelor group, and the clopidogrel group is around 3.8. So if you see this, there is significant reduction in the stent thrombosis in patients who are on ticagrelor when compared with clopidogrel. Next slide. So if you see the time to major bleeding from the primary, which was a primary safety event, it was slightly more in ticagrelor group when compared to clopidogrel. Clopidogrel group, there was around 11.2 percentage of chances of bleed, whereas in clopidogrel 11.2, and ticagrelor was 11.5. There's a 0.38 slight increase in bleeding risk, but it was not statistically significant. Next slide. So the other trial was Pegasus TIMI 54 trial, where efficacy and safety of ticagrelor over at a time in patients with prior MI was seen. Next slide. So it was a study on 21,000 patients, randomized, double-blind, placebo-controlled parallel group study, and 2 doses of ticagrelor, either 90 milligram twice daily or a slightly lower dose, 60 milligram twice daily, co-administered along with aspirin. And it was compared to aspirin therapy alone in patients with history of MI. So the primary endpoint was that the composite of first occurrence of CV death or fatal or non-fatal stroke, and secondary endpoint was CV death and all-cause mortality. Next slide. So if you see, when compared with placebo, the incidence of cardiovascular death, MI or stroke was significantly reduced in patients who were on ticagrelor, and the dose of 90 milligram and 60 milligram, the incidence of endpoints were almost similar. So it didn't make much difference whether the patient was receiving 60 milligram or a 90 milligram, because the incidence of major endpoints were almost the same. It was only 7.8%, whereas in placebo it was around 9%. Next slide. So if you see the incidence of bleeding, so when the patients who were on ticagrelor 90 milligram, which is shown in the graph as a red color, and ticagrelor 60 milligram, which is shown as a blue color, and placebo is shown as the green color. So there was a slight increase in major bleeding in patients who were on ticagrelor 90 milligram, and minor bleeding was almost similar in both groups, and the fatal bleeding or intracerebral hemorrhage is also same. And overall, if you compare, the fatal bleeding was almost the same or even slightly less in ticagrelor 90 milligram group, and when compared with the ticagrelor 60 milligram group or placebo. Next slide. So let us see what is the 2020 ESC guidelines for the management of acute coronary syndromes in patients presenting without persistent ST segment elevation. Next slide. So the recommendation for NST elevation acute coronary syndrome without atrial fibrillation undergoing PCI, aspirin is recommended for all patients without contraindication at a dose of 150 to 300 milligram loading dose, followed by either 75 to 100 milligram once daily on a long-term treatment. And a P2Y2 receptor inhibition is recommended in addition to aspirin and maintained over 12 months unless there is contraindications or excessive risk bearing. That is, DAPT dual antiplatelet regimen has to be continued for 12 months if the patient is going in for intervention. And for this P2Y2 receptor, the options are either prasugrel to be given proceeding to when the patient is proceeding to PCI 60 milligram loading dose, and 10 milligram daily as a standard dose, and 5 milligram daily for patients aged more than 75 years or with a body weight of less than 60 kg. And ticagrelor, irrespective of the planned treatment strategy, invasive or conservative, initially we can give us a 180 milligram of a loading dose followed by 90 milligram twice daily. Or the third option is give Clopidogrel 300 to 600 milligram as loading dose followed by 75 milligram once daily, only when prasugrel or ticagrelor are not available and cannot be tolerated, or when they are contraindicated. So Clopidogrel is given only if the patient is not going in for intervention, or if it is not available, or if they cannot tolerate ticagrelor and prasugrel. Next slide. So now we'll see the treatment options for extended dual antithrombotic or antiplatelet therapies. Now, combining antithrombotic along with an antiplatelets, that is called as a dual antiplatelet therapy, antithrombotic therapy, extended treatment, including aspirin. So rivaroxaban, that's a COMPASS trial. Rivaroxaban 2.5 milligram twice daily was given in patients with CAD or symptomatic peripheral artery disease at high risk of ischemic events. And that is otherwise DAPT, that is a dual antiplatelet therapy, aspirin along with either clopidogrel, prasugrel, or ticagrelor. So this has to be continued as DAPT. So either aspirin with rivaroxaban or DAPT. This was a this is that we see in this slide. Next slide. So from this, what we understand is any patient with acute coronary syndrome, if they are willing for intervention, definitely load them with aspirin plus either prasugrel or ticagrelor. If they are not willing for intervention, they are willing only for if there is an ST elevation, if they are willing for a thrombolysis, or NST elevation, if they are not willing for intervention, we can continue with aspirin, clopidogrel, and proceed with further treatment. So, so about the various combinations, I think probably we'll ask the panelists to discuss, or we'll go in for the second case presentation.
Sir, you can ask panelists to discuss if on the case how to manage.
Yeah. So I would like Dr. Ramanathan and Dr. Surendran and Dr. Muthaya to express their experience as well as views based on various trials, which antiplatelet or which antithrombotic you prefer in ST elevation MA and non-ST elevation MA based on their profile. Yeah, Dr. Surendran.
Since we have data regarding ticagrelor, it's obviously better option than clopidogrel if you're planning intervention. And as far as prasugrel is concerned, it's better to avoid it unless we know the anatomy. Without knowing the anatomy, if you load with prasugrel, again, there may be a lot of issues to deal with. And the access point bleeding and so many bleeding issues might also be there. And in our setup in Omandura, we do give prasugrel for a lot of patients. Our heads prefer that, but we've also seen some. I think it has to be individualized on the basis of the patient also. A lot of thin females with low body weight, we have to be very careful in giving prasugrel. We do get a lot of access site complications and major bleeding issues also. I think prasugrel should always be taken with a pinch of salt. And as far as ticagrelor is concerned, it's a safer alternative when planning for interventions compared to clopidogrel. And we all know that obviously ticagrelor has got lower rates of ischemic events, and one of the reasons is because of its pleiotropic effects. In addition to these routine antiplatelet effects, it has also got it also increases the adenosine levels, which also works on the microcirculation as well as it's got coronary vasodilatory effects, and that also adds to the benefit of its anti-ischemic effects. And whereas it also leads to the known side effects like bronchospasm as well as bradyarrhythmias. So one of the issues that I want to discuss with you, sir, is in inferior volume, patient is already prone for bradyarrhythmias. And when giving ticagrelor, how often does it aggravate the bradyarrhythmia? And in your experience, how often do you deal with that complication? Have you ever seen that?
Very rare actually. Even though I think in papers they say the incidence is high, but practically I think we don't see much bradycardia in even in inferior VLMI. When we use ticagrelor, we don't see much of a bradycardia practically.
And they also say that the bronchospasm, the dyspnea is actually decreased when ticagrelor is taken along with coffee because it increases the adenosine levels. That's
initially I think they were having a lot of hypotheses for the reason for dyspnea in the patients on ticagrelor, but then finally they say it is because of the bronchospasm. But that way I think practically in our Indian patients, I've seen few patients who came with breathlessness, but it's very rare actually.
One incidental observation was like in Middle East patients, we had so many of them coming back with breathlessness on the second day or third day. But if we are able to convince them to continue the ticagrelor, within a week's time, breathlessness settles down. I didn't come across who came with breathlessness. They never came back telling that they had breathlessness and all those things. Only in particular Middle East group of patients, I did find out that most of them had on the second day or third day severe breathlessness.
Dr. Ramanathan?
I'm not sure if it's in the picture right now. Sir, yes.
Yeah, he's there, yeah.
Yeah. So regarding prasugrel, I think one of the initial reasons using Prasugrel was probably the cost associated with the Ticagrelor initially when it was still in the patent field. But now subsequently following the patent expiring, costs have come down. So I don't think it makes any sense for us to continue to use Prasugrel at all. And likewise, even you must have observed hardly in clinical practice you will come across patients being on Prasugrel. So I think Ticagrelor having less bleeding complications when compared to Prasugrel makes more sense than using it. And I just wanted an open question, like when you need to use triple therapy, so when there's an indication for using anticoagulation, triple therapy for how and what would be your preferred regimen to switch over as for an antiplatelet with an anticoagulation is concerned?
I think that is a debate today. We'll have to discuss on that now, because many of our patients, especially elderly patients who have a CAD with atrial fibrillation, so we definitely give antiplatelets as well as an antithrombotic. So we sometimes we are in confusion which drug to choose and other things. What is your experience?
I just wanted to know your personal opinion as to what you do in your personal practice. Do you give triple therapy at all, or as early as possible switch over to a single antiplatelet with an anticoagulant?
I think every individual patient will have to assess their risk of bleeding as well as the risk of thrombosis. So if the risk of thrombosis is high and the risk of bleeding is less, definitely we can go in for a dual antiplatelet along with the antithrombotic agent. Whereas if the bleeding risk is high and the thrombotic risk is low, then probably we can just manage with a dual antiplatelet and I can avoid an antithrombotic. So every individual patient, I think we need to assess, and then accordingly we'll have to adjust the dose of antiplatelet as well as the antithrombotic. But I have seen many patients I have treated with a dual antiplatelet along with an antithrombotics, and I have had 1 or 2 patients who had a major bleed, but then if you see the risk-benefit ratio, definitely I think in high-risk patients for thrombosis, we can consider dual antiplatelet with an antithrombotic. And if you ask me which agent, probably when I use Ticagrelor or Prasugrel, I usually prefer apixaban. Whereas if I am using aspirin and clopidogrel, I usually prefer dabigatran. The advantage of the dabigatran is we have got a reversal agent, like Praxbine. So in case if they develop any fatal or very high risk intracellular hemorrhage, or if the patient develops some other complication needing a non-cardiac surgery, we can immediately reverse the effect of dabigatran by giving the reversal agent. Whereas other rivaroxaban, it doesn't have a reversal agent. So that is another added advantage for dabigatran. What about your experience, Dr. Surendran, your opinion?
Depending on whether it's stable or an ACS, also will have to decide. As the case of stable CAD, after stenting, I think a very short span of triple agent is enough. I think you can stop even after a period of 1 week to 10 days. You can go on to dual antiplatelet agent in case of a stable CAD. In the case of an acute coronary post ACS, I think you'll have to give a slightly extended dose of triple agent. It's better.
Maybe up to 3 months or 6 months we given, especially if the intervention, if you find the thrombus burden is high, and probably the antithrombotics will help. Maybe you can give up to 3 months or 6 months, and then even up to 12 people are given up to 12 months without major bleed.
Any experience in these type of patients? We have used 60 milligrams of Ticagrelor along with an anticoagulation. Have you come across anything?
Actually, most of the patients, when we give triple drug, we prefer 60 milligram of Ticagrelor rather than 90 milligram. Because 60 and 90, they say it doesn't have much difference for the effect. So whenever I use triple therapy, I use 60 milligram of Ticagrelor.
In your experience, have you tried switching out to ticagrelor or monotherapy, sir, after 3 months?
There are some patients whom, because they have probably a minor bleed and other things, have reduced to 90 milligram for a few days, and then I change over to either 60 milligram twice or 90 milligram twice. I've managed some patients with 90 milligram once for 3 months, 6 months, like that, without any thrombotic events.
I think most of the times that we need to do that is when patient has a GI bleed or something like that. A few elderly patients of mine, they have to stop aspirin and continue with ticagrelor or monotherapy alone. They seem to be doing fairly well. They do not have any subsequent GI.
Elderly patients who come with GI irritations, we change them to ticagrelor alone after 3 months or 6 months, and then they do pretty well. Medically managed elderly patients, we continue with just ticagrelor alone. And after a year, we switch over to 60 BD without aspirin.
Earlier, the ticagrelor was very expensive and they had only a one molecule monopoly. Now I think it is the cost value is almost equal to clopidogrel. Doesn't make much difference. So shall we proceed with the second case? Yeah, this is about stroke prevention in atrial fibrillation SPAF, where we use antithrombotic. So this is an example of 55 years old female presented OPD with history of palpitation 2 days back. Lasted for approximately 15 minutes. Similar episode she had 3 months back also. Known hypertensive on telmisartan, but not taking regularly. No history of diabetes, no history of CVD, no history of any major bleed. She comes from an upper middle class family. She's not on any antiplatelets or anticoagulants. Blood work was almost normal and ECG was normal. And echocardiogram showed normal valves and chambers, good LV function, no clots, no vegetation, and pericardial effusion. So this is a typical case of a paroxysmal atrial fibrillation. And when a 55 years old female, definitely we should think about starting an anticoagulant because she has a high risk of developing stroke because of this paroxysmal atrial fibrillation. Ideally, we need to do a Holter monitoring, which may not pick up in the first 24 hours. So we may have to do a 7 days or 14 days Holter monitoring. Even if sometimes 14 days monitoring doesn't record atrial fibrillation, on clinical suspicion, we can start them on antithrombotics. Next slide. So clinical examination was normal, all system, and this patient 24 hours Holter monitoring was done. It showed a short run of atrial fibrillation approximately around 10 minutes. Next slide. So this is a typical case of paroxysmal atrial fibrillation. So what to do next? Points to be considered at: should we start the patient on oral anticoagulant? If yes, which anticoagulant to be used? Vitamin K agonist or a NOAC? And how long we should continue? Do we need to consider the following points like age of the patient, cost of the therapy, drug-to-drug interaction, compliance with the drug, ability to do regular monitoring, and cardiovascular risk, and the risk of bleeding and ischemia. Next slide. So next question need to be answered is about the various parameters we assess in patients with atrial fibrillation about the bleeding risk. That is a CHAS-2 score and a HAS bleed scoring. And should we put her on anticoagulant or an antiplatelet or nothing? And what is the latest ESC guidelines recommends? And if anticoagulation, then vitamin K antagonist or a NOAC. Next slide. So this is a score for assessing the stroke risk assessment with the CHAS-2 and VASC scoring. So if the patient has a congestive heart failure or LV dysfunction, the one point is added, hypertension 1 more point, age more than 72 years is 2 points. And if there is a earlier stroke or a transient ischemic attack, 2 points. And if there is any vascular events like prior myocardial infarction or peripheral aspirin, it's 1 point. If the age is between 65 to 74, 1 point. And if the female gender, another 1 point. So and if you see, if the CHAD score is 0, the chances of having stroke is less. If the CHAD score is 9, there is a 100% chance of this patient developing stroke over a period of 1 year. So based on this CHAD-2 score, we definitely need to start them on antithrombotic. Next slide. So HAS is another score, Has-Blood score to estimate the risk of bleeding. The patient has hypertension, then 1 point. Abnormal renal or liver function, 1 or 2 points. Stroke history, 1 point. If there is a previous bleed, 1 point. And if is an elderly patient more than 65 years, 1 point. If the patient is an alcoholic, 1 or 2 points, so maximum of 9 points. So as the score increases, the chances of bleeding also is more. So we need to balance the thrombotic risk as well as the bleeding risk, and then decide about starting the antithrombotic. Next slide. So what is the latest ESC guidelines say of the Task Force for Diagnosis and Management of Atrial Fibrillation of European Society of Cardiology? Next slide. So patient with atrial fibrillation, if they are eligible for oral anticoagulation, of course, if they have patients with prosthetic mechanical valves, or if they have a moderate mitral stenosis, then we have no other option than vitamin K antagonist. So any patient who are on mechanical heart valves, or if they have patient has severe mitral stenosis, then we'll have to give vitamin K antagonist. Yeah, otherwise we can go in for NOAC. If there's a low stroke risk, then we can just manage such patients with antiplatelets, and there is no specific antithrombotic treatment needed. So there is this stroke risk is high, which we assess based on this CHAD-2 score. And if you'll have to calculate the Has-Blood score or the bleeding score. So based on this, so either definitely we'll have to start them on oral anticoagulant agent or vitamin K antagonist. So either of these has to be considered in such patients who are eligible for anticoagulations in atrial fibrillation to prevent the stroke. Next slide. So the antithrombotic therapy, there are options are like earlier they were used to give warfarin alone or warfarin with aspiration, with aspirin, warfarin with aspirin plus clopidogrel, or warfarin versus dabigatran. So the study showed that when the patient is put on dabigatran, definitely it favors better treatment when compared with warfarin or aspirin or clopidogrel. Next slide. So there's a recommendation for stroke prevention in patients with atrial fibrillation. There is a class 1 11A indications. The oral anticoagulant therapy to prevent thromboembolism is recommended for all male patients with atrial fibrillation with a CHAD-2 VAS score of more than 2, and for female patients for a score more than 3. And it is considered in male patients with CHAD-2 VAS score of 1, that is class 2A level P indication. And when oral anticoagulation is initiated in a patient with atrial fibrillation who is eligible for a NOAC like apixaban, dabigatran, endoxaban or rivaroxaban, then a NOAC is recommended in preference to vitamin K antagonist with a class 1 level A indication. So definitely this shows that newer oral anticoagulant is definitely superior to vitamin K antagonist in various at various levels. Next. If you give oral vitamin K antagonist, we need to monitor the PT-INR, especially in our Indian setup. Many patients, if you ask them to do a PT-INR and come after 1 month, they will come after 6 months. Some patients land up with bleeding. They don't do a regular blood test, etc. That is the main disadvantage of warfarin. So, but still we can see that warfarin and azenocomarol is widely used in India. And NOACs which are available in India, dabigatran, rivaroxaban, and apixaban. Next slide. So as I was telling, the limitation of vitamin K therapy, vitamin K antagonist therapy as food-drug interaction, drug-to-drug interaction, and which has got a narrow therapeutic window, slow onset and offset of action, routine coagulation monitoring used, and frequent dose adjustment. We have seen patients who are taking 6 milligram, 7 milligram of acetron, but INR will be very low, like 1.5. There are some patients who take just 2 milligram and they come with an INR of 4 and 5, and the risk of bleeding is very high. So the drug response varies from individual to individual in vitamin K antagonists. Next slide. So if you see the comparison of NOACs, dabigatran, rivaroxaban, apixaban. Dabigatran is a direct oral thrombin inhibitors, whereas rivaroxaban and apixaban is factor 10 inhibitors, and the time to peak level is 3 hours in dabigatran. It's almost same in others also. Half-life is 12 to 17 hours in dabigatran, and 80% is renal excretion in dabigatran, and the dose is 150 milligram and twice daily, or 110 milligram twice daily. Whereas rivaroxaban, the excretion is 66% is liver and 33% is renal, whereas apixaban is 27% is renal. So, study all got their own study, like dabigatran, there's a relay study. And rivaroxaban, it is proved as in the Rocket AF trial, and apixaban by Aristotle trial, it is proved to be useful in stroke prevention in atrial fibrillation. Next slide. So comparison with other NOACs, the dabigatran definitely is superior when compared to other NOACs. So a direct comparison of commercially available NOACs in a prospective head-to-head trial has been performed, and research refer to doses compared to head-to-head trial with warfarin in each trial. And all trials had stroke or systemic embolism as a primary endpoint, and time to therapeutic range was also considered in these trials. So, for a primary endpoint, the dabigatran 150 milligram was superior, whereas 110 milligram was right. It was proved to be non-inferior, and the prevention of ischemic stroke, it was superior, 150 milligram twice daily, and for hemorrhagic stroke and intracranial bleeding or any bleeding risk, it was superior, both 110 milligram and 150 milligram. Next slide. So as I was mentioning about these trials, like for dabigatran, relay was 110 milligram, and relay 150 milligram was also done. And for rivaroxaban, it was Rocket AF trial. So overall, when you compare all the other agents, dabigatran at 150 milligram twice daily was superior in stroke prevention as systemic embolism, and also in preventing the ischemic stroke, and also it doesn't cause much of hemorrhagic stroke. Next slide. And these are all indirect comparison. There is no head-to-head comparison at all in there. If there was a slight increase in GI bleed in patients who are getting dabigatran 150 milligram twice daily, and also in rivaroxaban group. Next slide. Yeah, so the only advantage I was telling is about dabigatran is the availability of reversal agent. So that makes a lot of difference, because I had a patient who was on dabigatran 150 milligram twice daily. The patient came with a intracerebral hemorrhage, and we could immediately, within 6 hours, we could arrange the Braxpine, and when we gave, they were able to inject it within around 7 to 8 hours from the onset of intracerebral hemorrhage, and we could save that patient, because immediately the effect of dabigatran was neutralized. So you can discuss on this. What is your preference of NOACs in SPAF? So then your opinion about this?
Yes, sir. The presence of a reversal agent is a big hope for us when we are giving, especially for elderly patients. a very good option. But coming to the current scenario of COVID cases, which one we all use rivaroxaban, but is dabigatran an equally potent or equally studied? Do you have any experiences regarding that?
Even I have seen, because I don't treat COVID patients, but I have seen most of the COVID centers, when the patient is being discharged, they advised rivaroxaban 2.5 milligram twice daily. But I don't know the exact reason, because there is no trial in for NOACs in COVID patients. So probably their individual preference is rivaroxaban, but I really don't. I think it will be the same effect in with other molecules also.
Basically, it has been promoted like that, rivaroxaban, but dabigatran promoted like that.
Probably.
We have been using dabigatran for all this.
Voice is not audible.
Rivaroxaban was not much used earlier, so they thought COVID as an opportunity, and then they promoted it. They used it at the right time, probably. But dabigatran, since it has got a reversing agent, like it gives us the solace that we can easily use it and then get the desired results also. Like 150, we were comfortable using it on most of the patients. Like so, that way I think dabigatran scores in AF stroke prevention in AF patients. So we didn't use much of rivaroxaban and apixaban earlier, but now since they thought it as an opportunity and then they pounced on it probably.
Yeah, tell me.
In CAD patients, when you're going for triple therapy, which of the agents would you prefer, sir? Of which of the NOACs?
I have used both dabigatran as well as rivaroxaban. I think both seems to be equally effective and safe. The only advantages I was telling is the reversal agent with dabigatran. Especially elderly patients, if they land up with bleed, we don't have an option when the patient is rivaroxaban. So when the patient is on dabigatran, at least we can give Praxmine and immediately reverse the effect of the agent. That's an advantage.
Any experience with using low dose rivaroxaban in stable CAD patients, sir?
I have seen, and even I have used in acute coronary syndromes, small dose of rivaroxaban like 2.5 milligram once daily or twice daily. We have given in many patients with acute coronary syndrome, along with diabetes. When the thrombus burden is high, or when there is a small LV clot, or if the apex is dyskinetic, when there is a chance of LV clot formation, we have used rivaroxaban 2.5 milligram twice daily along with the DAPT in such patients. For a chronic yeah, but for a chronic stable angina, I don't think there is no active role for NOACs, unless otherwise they have any atrial fibrillation or other associated DVT or pulmonary embolism.
Considering the COVID scenarios, since many of the patients would have been exposed to COVID at some point of time, maybe a month ago, and most of them, some of them might come with an acute coronary syndrome. When treating these patients, is DAPT sufficient, or do we have to initiate? For example, a patient who's already exposed a month ago with COVID comes to us with an acute coronary syndrome. We're doing PCA for that patient. Obviously, we're starting DAPT. Along with that, we need to start NOAC to be on the safer side. What's your response?
Definitely, I think because thrombotic risk in a COVID patient, they say it is there up to 3 to 6 months also. So I think it is always safer to have, because I've seen so many patients presenting with pulmonary embolism in COVID situation. After 1 week, 2 weeks, they develop pulmonary embolism. Many patients in my hospital who have been thrombolized with that. So definitely, I think the thrombotic risk is very high, and it goes on for 3 to 6 months post-COVID. So probably after the intervention, PCA, we need to start them on a small dose NOAC. And we have seen that D-dimer is elevated even after 3 months of some patients post-COVID. Even after 3 months, the D-dimer is elevated.
So, just wanted to share my experience regarding a recent patient which I did last week. Patient post-COVID, 1 month later, now he is presented with inferior wall MI. Usual routine angioplasty done. He was discharged. 2 days later, he comes with hemoptysis. Patient has had a pulmonary hemorrhage. So the other side of, I don't know whether it is because of antiplatelets or we use some tirofiban also during the procedure because he was having a lot of thrombus also. So whether it was because of tirofiban or whether it is anything to do with COVID, whether it is because of LV dysfunction that he had. So
very difficult to find out what is the reason.
Yeah.
But to be on the safe, to be on the safe side, we always give a higher dose of antiplatelets and antithrombotics. But then sometimes we land up with bleeding and then we'll be in trouble.
It's very difficult to decide what is exactly needed for that patient. Fortunately for him, he's not progressed. He's been doing subsequently, he's stable. I had to stop ecosprin alone for a few days, continuing ticagrelor alone. I'm keeping my fingers crossed, but nothing else that can be done.
Any other questions from the audience?
Yeah, there is one question from the audience, sir.
Yeah.
The question is, I want to start NOAC, it is dabigatran to my future AF patient. So I should go for up titration and down titration. Please suggest.
The question was not clear. Just repeat it.
I want to start dabigatran to my patient in future AF patient. So should I go for up titration, down titration? Please suggest.
The up titration, down titration has to be done if there is any bleeding or if the effect is the target effect is not reached. If there is bleeding, definitely we need to down titrate. Otherwise, we can continue with whatever high dose they are receiving.
There's one more question. My AF patient who is about to go a PCI, he's on NOAC right now. So after the PCI, what therapy should be the course of action, like DAPT plus AF, or please suggest in that case?
Definitely, yeah. Those patients, I think DAPT plus NOAC has to be continued because patient has an atrial fibrillation. So even post PCA, the atrial fibrillation is going to continue and the risk of stroke is there. So you can continue the DAPT along with the NOAC. There's no problem.
Yeah, no more questions, sir. Thank you. Over to Ganeshan.
Yes, sir. So thank you so much, sir. I came here for a vote of thanks. We take this opportunity to thank Dr. KP Samsudin, sir, for moderating the panel discussion and ensuring the audience are enriched with the clinically relevant messages. And also we thank Dr. Ramanathan Ramkumar, sir, and Dr. G.D. Surendran, sir, and Dr. Muthaya, sir, for sharing their clinical experiences, sir. And also we would also thank all the doctors who have joined us for this panel discussion. We at Alchem Laboratories will continue to serve doctors and patients for making our products available, especially in this pandemic situation. Our TSAT and our Debiclot, Debigatran, and our Ticagrelor is available now. So thank you once again, sir, all the panelists and moderator. Thank you so much, sir, for this wonderful session.
Yeah. Thank you, Surendra, Ramanathan, and Muthaya.
Thank you, sir.
We'll meet sometimes, maybe post-COVID.
Definitely, sir.
Thank you.
Bye.
Thank you,
Bye,
sir.
sir.
Bye, sir. Thank you.
Take care.
Yeah. Bye.